Dear colleagues, my topic is devoted to value of the extravascular lung water. My name is Mikhail Kirov and I represent Northern State Medical University from Arkhangelsk, Russian Federation. Here you see our city, our university, and some sightseeings from the north of Russia. And here you can also see my conflict of interests. During critical illness, especially in cardiac patients and in patients with capillary leak syndrome, we can observe pulmonary edema and increased extravascular lung water. The possible mechanisms for accumulation of lung water include changes of fluid filtration in the pulmonary vasculature due to increased capillary or interstitial hydrostatic or oncotic pressure, deteriorated lymphatic drainage, and worsened permeability. To measure lung water, we can use different methods, from clinical examination and evaluation of blood gases to radiological methods like chest X-ray, CT, lung ultrasound, etc. However, to measure lung water quantitatively, the gold standard in experimental setting is postmortem gravimetry. However, it is impossible in clinical situation where we can use thermodilution techniques with thermodilution that has been replaced during the last 20 years by a single transpulmonary thermodilution. Here you see the main principles of the method. When we give bolus injection of cold normal saline into the central venous catheter, it passes through pulmonary and systemic circulation, changing the temperature of the blood that is detected by a thermistor on the tip of femoral artery catheter. And the monitor analyzing these changes based on Stewart-Hamilton method builds up the thermodilution curve, and analyzing the decay part of this curve in addition to cardiac output, the monitor can estimate the extravascular lung water content, reflecting the severity of pulmonary edema. To measure lung water, we can use different monitors, echo monitors, PulseFlex, volume view, and several manufacturers of medical device use modules based on Pico technology to measure extravascular lung water together with other parameters on the main screen. The lung water measurements using single thermodilution have been validated both in experimental and in clinical setting. This is our study in SHIP at the University of Tromsø in Norway, when we have validated lung water measured by gravimetry and by thermodilution with single transpulmonary thermodilution, observing a moderate correlation. Also, lung water measurements have been correlated in non-survivors of critical illness by our Japanese colleagues, demonstrating that the normal lung water value is close to 7 mL per kilogram. Thus, the increased lung water is more than half a liter in adult patient. And if we see lung water exceeding 10 mL per kilogram, we can see pulmonary edema with foam from the pulmonary root. The lung water value close to 10 mL per kilogram allows us to diagnose the diffuse alveolar damage with a good sensitivity and specificity. And as has been shown both in our studies and in studies of Greg Martin, we see that the peak of the increase of lung water during sepsis and ARDS is typical for the 3rd to 4th day from the onset of critical illness. Thus, in case of increased pulmonary permeability, even moderate volume expansion can lead to significant increase of lung water. To measure the degree of capillary leak, we can use pulmonary vascular permeability index, that is a ratio of lung water to pulmonary blood volume. In case if it is more than 3, it can be an additional sign of non-cardiogenic pulmonary edema. It has been shown both in our studies and in studies of Japanese, French, and other authors that pulmonary vascular permeability index, together with lung water, has a prognostic value and can be a useful diagnostic tool for ARDS. Increasing in parallel with severity of ARDS together with lung water. In our recent book devoted to advanced hemodynamic monitoring, together with other authors, we have analyzed the value of lung water and pulmonary vascular permeability index in light of recent publications. And we see that the non-cardiogenic pulmonary edema, when PVPI is close to 3 and exceeds this value, is a clear sign of severe ARDS. Certainly, the method of analyzing lung water using thermal dilution has also some limitations, like pulmonary embolism, inhomogeneous lung damage, lung resection, low cardiac output, and intercardiac shunting, as well as some other limitations. However, in most cases, if used together with cardiac index and volumetric parameters, lung water can be a useful alert to stop fluid therapy, to think about administration of inotropes in case of increased lung water values, and target lung water values below 10 mL per kilogram. Thus, lung water is included into the recommendations of the Task Force on Hemodynamic Monitoring. You see that if we see increased lung water, it can be additional alert for careful titration of fluid management. And as has been shown in a recent review of Daniel De Baker, lung water can be additional tool for analyzing the severity of hemodynamic and pulmonary deteriorations in circulatory failure refractory to ordinary management. During stages of shock, lung water measurements can be useful during optimization, stabilization, and de-escalation phases, like in this patient from our ICU, when we can titrate fluid load, ultrafiltration rate, and manage mechanical ventilation using this kind of monitoring. It has been shown that lung water can be also used during weaning from ventilation, and the increased lung water can diagnose weaning-induced pulmonary edema with a good sensitivity and specificity. Also, in a recent study by Jean-Louis Thibault and Xavier Manet group, it has been shown that in ARDS patients, reducing of PEEP leads to decrease of lung water, and the opposite, increased PEEP again leads to increased lung water. Thus, it can follow the changes in PEEP in ARDS. In cardiogenic pulmonary edema, lung water can be useful tool to analyze its decrease during diuretic therapy, and its decrease is accompanied by improved lung function, and the therapy guided by these parameters together with other volumetric and fluid responsiveness variables can change the fluid strategy and reduce the incidence of acute kidney injury after cardiac arrest. In burns, fluid therapy can be accompanied by pulmonary edema, and the patients with burns exceeding 30% of body surface area can be managed using lung water and cardiac output, and they receive less fluids and have better hemodynamic stability and lower incidence of cardiac and renal failure. However, in burns, to avoid tissue edema, the volumetric parameters as the endpoints for fluid resuscitation should be adjusted to below normal values. In subarachnoid hemorrhage, we can observe pulmonary edema during fluid therapy, and as shown by Japanese authors, the measurement of cardiac index, lung water, and PVPI can be useful to identify pulmonary edema in these patients over time and manage the fluid management. Lung water can be a part of perioperative goal-directed therapy, as has been shown in case of the hyperperfused patient with increased lactate with hemodynamic instability. The next step can be thermal dilution measurements with lung water. After pneumonectomy and lung resection, lung water measurement can help to detect post-pneumonectomy pulmonary edema, as has been shown in our study when it is increasing, peaking between 18 and 36 hours. After pulmonary endarterectomy, the reperfusion pulmonary edema can be detected by lung water with a good diagnostic value. And after esophagectomy, as shown by a number of studies from Japan, lung water can also be elevated within 24 hours after surgery due to deteriorated lymphatic drainage after lymph node dissection. After coronary surgery, lung water decreases in parallel with therapy, and as has been shown in study of Matthias Goepfert and colleagues in coronary artery bypass grafting and aortic valve surgery, the fluid therapy guided by volumetric parameters and lung water can decrease need for norepinephrine, pulmonary complications, and ICU stay. Here, the authors suggest higher value of lung water for the management. And in our review on hemodynamic therapy in low cardiac output syndrome, we suggest also to use lung water as one from the indications for administration of furosemide and for fluid therapy. Certainly, in addition to thermal dilution measurements, we can estimate lung water qualitatively by using lung ultrasound. It has a lot of indications from asthma and hemodialysis patients to obstetric pediatric patients and chronic heart failure patients when thermal dilution method is too invasive. And it can also be used in COVID patients, as shown in this ultrasound figure from our patient with number of B lines in parallel with increased pulmonary edema. However, the diagnostic of lung ultrasound to quantify lung water is different. We see that the sensitivity is ranging from 50 to 98%, and the specificity is also different in different studies. Thus, further research is needed, and one from possible solutions would be such elegant device with ultrasound crystal to detect lung water non-invasively. Also, the computed tomography can be a useful tool to evaluate lungs, but as shown in our study together with Bernd Zagel, the CT-derived variables do not predict elevated lung water values, and these methods for estimation of lung water, both thermal dilution and CT, are not interchangeable in critically ill. Thus, the monitoring of lung water can include following indications: severe shock, ARDS, sepsis, acute cardiac failure and pulmonary edema, severe burns exceeding 30%, subarachnoid hemorrhage, multi-organ dysfunction syndrome, and major complicated or high-risk cardiac and non-cardiac surgery. In these situations, the measurement of lung water together with other complex monitoring parameters can change the strategy for fluid, inotrope, vasoconstrictor, or diuretic administration in a significant number of cases, as shown in this multicentric study. In COVID-19, we see that lung water can also be useful. As shown in the study from Paris, the patients with COVID-19 have higher lung water value and PVPI as compared to non-COVID patients. And the higher lung water reflects a non-cardiogenic pulmonary edema in these patients and can serve as a parameter to monitor ARDS progression. You see the decrease in lung water in patients who were discharged early from ICU and the increased lung water in more severe patients staying in ICU in this recent study. This is an example from our ICU case showing the lady with severe ARDS after COVID and cesarean section with severe lung damage requiring nitric oxide and other novel therapies, and the lady after extubation receiving higher flow oxygenation. And there is here increased lung water exceeding 20, and then decreased lung water during fluid restriction, and then after the transfer to another hospital, again increased lung water and again normalization during fluid management with the resuscitation. As shown in a recent review and meta-analysis published in Critical Care, analyzing more than 1,000 patients, the value of lung water is associated with mortality in critically ill, increasing the chances for mortality. And lung water is significantly higher in non-survivors, approximately by 5 mL per kilogram. Thus, The measurement of lung water allows early diagnosis of pulmonary edema and has a prognostic role in critically ill patients and high-risk postoperative patients. And together with clinical science, hemodynamics, and other data, monitoring of lung water can be a useful tool for the personalized therapy in the ICU. Thus, I hope that lung water can serve a useful guide to pass between cellular hypoperfusion and charybda of pulmonary edema. Thank you for attention.
Thank you very much, Mikhail, for this very clear and comprehensive presentation. By the way, for the participants, do not hesitate to ask your questions on the chat. I can read these questions just with a pad just in front of my eyes, and I will repeat your questions. Mikhail, the first question is this one. Many colleagues tell me when I speak about extravascular lung water measured by transpulmonary thermodilution, tell me that in their daily practice, they don't need this invasive, expensive device. They use lung ultrasound. You mentioned it on the slide, but can you comment a bit more on that? What is the difference between lung ultrasound and extravascular lung water? What does the one and the other allow? And what do you think that they are interchangeable? You suggested that's not, but can you comment a bit more?
Bonjour, Xavier, dear colleagues, good morning. Really, in many cases, lung ultrasound can be helpful to diagnose pulmonary edema, but as we have discussed earlier, it cannot assess the severity of pulmonary edema at the same extent quantitatively as compared to thermodilution methods. And lung ultrasound can be used, for example, at earlier stages for diagnosing of pulmonary edema, and in many cases we can guide our therapy assessing the number of B lines, and if the patient is improving, that's okay. We can not go further with femoral catheterization and with thermodilution management, but the lung ultrasound is operator dependent. And again, if we need more exact estimation of pulmonary edema, especially in patients with combination of respiratory failure and shock, then the thermodilution measurements can provide better understanding of the pathophysiology of the disease, and can help us to manage this patient with much more details, including not only volumetric measurements, but also cardiac output, other preload parameters, and afterload to guide both fluid, inotrope, and vasopressor therapies with more clinical goals.
Mikhail, Ashraf Altayar still stands in front of me. As you know, he is an echo freak, and he has a question or comment for you.
Yeah, thank you, Mikhail, for this very nice presentation. I really enjoyed it. My question is to know from your experience point of view, what you do in the dilemma of septic shock and ERDS. And you see extravascular lung water are there, but whatever the mode you use to diagnose, lung ultrasound or the thermodilution. But my question is, when you have ERDS and you have septic shock patients that deem needing still IV fluid, do you stop giving IV fluid and you go with early vasopressors based on the extravascular lung water numbers, or you see lung width on lung ultrasound, or what you do actually? What's your advice for our colleague in intensive care?
If we have refractory septic shock with doses of norepinephrine exceeding 0.4, 0.5 micrograms per kilogram per minute, then we go directly to thermodilution measurements. But if the patient is less sick, then we can try to use lung ultrasound to receive an impression about the degree of pulmonary edema, and it can be really helpful in many cases. Thus, we use thermodilution mostly in refractory shock and in patients with severe ARDS. When anyhow we need the invasive monitoring to guide vasopressor therapy, and when we need the intra-arterial access for blood gases and for other analysis.
We need to go to the next presentation.
Thank you very much again. Thank you, Mikhail, for your presentation and the answers to our question. Thanks again. And now we move from the most invasive and the most expensive transpulmonary thermodilution to the least expensive and the less invasive way to assess hemodynamics, because we speak about clinical examination. Let's listen to the presentation of Afid Oufella from Paris, Saint-Antoine Hospital, and then we will ask our questions. There are some questions on the chat, but they arrived, I'm sorry, but they arrived just after closing the discussion. I will transfer your questions to Professor Kirov, and he will answer them directly. Let's listen to Afid Oufella.